A very good evening, ladies and gentlemen, students, parents, RMC colleagues, and welcome to another session of the Go Beyond Keynote Speaker Series, which is exclusively brought to you by RCSI UCD Malaysia campus as we commemorate 25 years of excellence this year in delivering high-quality medical education. Our first keynote session was held back in July, and fast forward to present, we are happy to see you all at the fourth session of this series. So thank you very much for joining us this evening. I'm Kasturi, the PR and Comm Specialist at RUMC, and I'll be your moderator for today. Before we begin, let me take you through a few items so you would know how to navigate around the platform. You should be able to see your attendee interface on your computer desktop on the right-hand corner. And by default, you're listening to this session using your computer speaker system, and you will be put on listen-only mode. You'll have the opportunity to submit text questions to our speaker by typing them out on the questions tab in the control panel. And please feel free to send in your questions at any time during the event. Now let's get started. Pink is stronger than you think. Pink October is commonly associated with breast cancer awareness. Although we are almost at the end of the month, the significance of Pink October should not be overlooked. Symbolized by a simple pink ribbon, it aims to raise awareness of breast cancer among women and to encourage them to step up their efforts in early detection of breast cancer. And in conjunction with this awareness month, today's keynote speaker session will provide you insights into breast cancer and its advances in research and treatment. Without further ado, allow me to introduce our distinguished speaker for today, Professor Arnold Hill. Professor Hill is a consultant breast surgeon and the professor and chair of surgery in the Royal College of Surgeons in Ireland. He graduated from University College Dublin in 1988 and did his basic surgical training in Dublin, followed by a middle grade surgical training in London. He then did a basic 2-year fellowship with Dr. John Daly at the Hospital of the University of Pennsylvania and the New York Hospital/Cornell Medical Center in the United States. He returned to Ireland to do his senior registrar training on the National Training Program in Ireland. He also did a clinical fellowship in surgical oncology at the Memorial Sloan Kettering Cancer Center in New York prior to taking up his consultant appointment, and his clinical interests are in the area of breast cancer and melanoma. Today, Prof. Hill will be sharing with us some essential information on breast cancer, current treatments, and potential changes in modalities. And without further delay, I would like to hand over the session to Prof. Hill. Prof, over to you.
Thank you very much, Kasturi, and thank you for that kind welcome. Can I just confirm that you can hear me okay?
Yes, Prof.
Perfect. Well, look, welcome to all my colleagues and good afternoon to my colleagues and friends in Malaysia. It's a great pleasure to be here, and it's just such a wonderful thing to celebrate 25 years of RUMC. It's been made an outstanding contribution to healthcare in Malaysia, and I'm delighted to be part of this 25-year celebration. My talk today, I have spent the last 25 years of my life specializing in the area of breast cancer, and I want to share with you some moments along that journey. And I've divided my talk today into 4 sections, and please feel free to type your questions into the chat, and then after about 30 minutes we'll stop and Kasturi will take the questions and we will answer those for you. So let's start off with the first, just to describe how I want to do this talk today. I want to first of all talk about sentinel lymph node mapping in breast cancer, because I think it's been such an important advance and a change in practice. The second section of my talk is on avoiding chemotherapy and how research has really made an incredible contribution to allow us to avoid chemotherapy in many cases. The next section is to talk about what now has become standard practice in breast cancer treatment is the wonderful advances in reconstruction, and where we've moved beyond implants to making very realistic reconstructions with DIEPs, and how important that has been to the recovery of patients. And I want to finish with a section on basic science, because I work with a whole group of scientists here in our research lab who have specific focus on asking different questions in breast cancer. And I want to share with you how that scientific endeavor can make a difference to our patients in the clinic. So if I go to my first section is on sentinel lymph node mapping, and why do I think this is important? Well, in 1999, I was doing a fellowship in Memorial Sloan Kettering Breast Cancer Center in the United States. And there was where I first noted, and it was first introduced into clinical practice, the concept of the sentinel node, that the sentinel node is the first node that drains a cancer from the breast. And at that time, the conventional standard treatment was to do a full axillary clearance for every woman with an invasive breast cancer. And what sentinel lymph node mapping did was it allowed us to be selective in who we needed to take out lymph nodes. And there was a huge body of work over the next 25 years in determining who actually needs a full axillary clearance. And we did many randomized trials looking at when was it safe to avoid an axillary clearance. And this was an area of great controversy. So let me just go through the technique first of all. There were two techniques. One is to use blue dye. And in fact, there were various different types of blue dye made. Lymphozurin was one of them, methylene blue, and now patent blue. And essentially, any blue dye that gets taken up by the lymphatics, it travels to the first node and gets trapped there. I use a technique myself where we would do massage of the breast after injecting the blue dye. We now know that giving it around the areola is the safest way because we know there's an anatomical plexus of lymphatics around the nipple areolar complex that allows the drainage of the blue dye to one lymph node. But that we showed way back in 1999 that if you used a combination of blue dye and isotope, you would be much more successful at identifying the sentinel node. So it's about an 80% success rate when you use blue dye alone, 85% when you use isotope alone. But when you use the combination of blue dye and isotope, you get a 97% identification rate of the sentinel node. And I think that's really, really an important message. So just to show the isotope, it's a little bit more complex. You need radioisotope available. You need a gamma probe, which in today's money, it's about 28,000 euros. So I'm not sure what that is, how much that is in your currency, but it's an expensive toy to have. And that was one of the issues in transferring this technology around the world, the expense of the isotope. But we published our first experience of 500 cases, and a number of lessons were learned. First of all, use both blue dye and radioisotope. We also learned that the concept of the sentinel node is very accurate. And we know that if the sentinel node is negative, it predicts with a great degree of accuracy that the remaining nodes will be negative, and therefore there's no need to proceed with an axillary dissection. And thus, you can reduce the trauma that was associated with an axillary dissection. And I think the biggest one of these that we have seen less of now is the risk of lymphedema and arm swelling. So this has been a major advance. It's now standard of care. There are many techniques for actually identifying the lymph node. And my own view would be that the most important thing is to find the lymph node, and whether you use blue dye alone, whether you use isotope alone, or the combination, I think it's very acceptable. The most important thing is to accurately find the sentinel node. But what the advent of sentinel node did for us was that it changed our understanding of how we stage patients with breast cancer. And when we previously talked about people being node positive, we referred to this concept of a macrometastasis, where there was a palpable lump in the axilla. But we found this whole new category of nodes, and we had to learn and try and find the meaning of what a micrometastasis is. A micrometastasis was where there was a tumor deposit that was less than 2 millimeters. And was that significant? And then there was this other concept where you just had a scattering of cells, and we call that isolated tumor cells. And then at an even more sensitive level, we had molecular techniques for picking up fragments of cytokeratin components in the node. So we'd gone from the days of feeling a palpable node with solid deposit into this whole new subcategory and staging. And we spent 2 decades trying to identify the meaning. So we traditionally, if people were node positive, would give them chemotherapy. Well, would you give them chemotherapy for a micrometastasis? Would you take out the remaining lymph nodes for a micrometastasis? And what would you do with isolated tumor cells? Was there any meaning to them? And at the same time, when this was happening in breast cancer, we were doing the same thing in melanoma. Now, what we learned in breast cancer was that a macrometastasis matters, but essentially a micrometastasis does not matter anymore. And neither do isolated tumor cells, and neither do cytokeratin stains on molecular techniques. So we'd spent all this time with the sophistication of identifying 4 subcategories within a sentinel node. And now we know 2 decades later, it doesn't matter in terms of clinical care. It's only whether they're macrometastases positive or not. The micrometastases, the isolated tumor cells, and the molecular techniques don't matter in terms of the outcome for the patient. And here's something really interesting. What confused us over the 2 decades was when we did this parallel set of studies in melanoma, it turned out that molecular techniques were very important and mattered in melanoma. So the biology of melanoma is different. And it certainly, we think, does influence outcome in melanoma if you are PCR positive using molecular techniques in your sentinel node. So I think that's important to learn. This was a staging technique. We learned about 4 subcategories, and we took 2 decades to realize that micrometastases, isolated tumor cells, and molecular techniques actually don't matter in terms of the outcome for the patient. I'm going to move on now and talk a little bit about avoiding chemotherapy. And I use that as a title because I think it's another significant advance in breast cancer treatment. We used to, 20 years ago, or even 10 years ago, gave chemotherapy to all patients who are node positive, or if you'd a large tumor. By large, I mean perhaps more than 3 or 4 centimeters. But we learned from biology and research that we were able to safely identify a group of patients who did not need chemotherapy. And this paper identified that less women need chemotherapy. It's this paper here in the New England Journal of Medicine, where it looked at a particular test called an Oncotype test and looked at women who were node negative, estrogen receptor positive, and HER2 negative. And this was a specific test looking at 21 genes within a tumor, and it gave you a score from 0 to 100. And this test was called the Oncotype test. And I'm just going to move forward 2 slides to say it was 21 genes where you take the patient's own tumor tissue and you look in great detail at these 21 genes. And the test is all done by Genomic Health, which is a company in the United States. And you get a score back between 0 and 100. And essentially, if you have a score less than 20, you probably don't need chemotherapy. If you have a score more than 20, you need chemotherapy. When we brought this into practice in our own unit here in Beaumont Hospital in RCSI and across Ireland, we have very good data to say that we reduced the amount of chemotherapy given for breast cancer by over 50%. That's pretty stunning. If I told you I had something that could avoid chemotherapy in 50% of women, you wouldn't believe me. But this test, the Oncotype test, reduced the amount of chemotherapy given for breast cancer by 50%. Now, it's worth noting there were other competing tests. There was one made in Europe, which is MammaPrint by a Dutch group using a slightly different technique. But again, trying to predict who will benefit from chemotherapy. And I want to just show you on the next slide what actually happens with Oncotype DX testing. You take the patient's tumor, you do the assay, you analyze the expression of the genes, you get a score between 0 and 100, and then you discuss with the patient whether it's safe to avoid chemotherapy. And what we learned from this was that the Oncotype assay was able to predict the risk of recurrence. We were able to identify patients who were predicted to obtain the most therapeutic benefit from hormonal treatment and that may not require chemotherapy. And you were able to identify patients with high recurrence scores who derive a greater benefit from chemotherapy. So we were now able to give a personalized approach to who would get chemotherapy. The next section I want to talk about is our chemotherapy drugs are getting better. And I want to share with you some slides as to how this has happened. This is a cartoon diagram of a breast cancer cell. And we all know there's an estrogen receptor on breast cancer, but probably the most exciting receptor over the last 2 decades has been the HER2 receptor. And the reason being is that we've a very exciting group of drugs that now work against HER2. The first drug was Herceptin. Then there was a drug called lapatinib. And we now have a drug called pertuzumab, which various combinations of these can now provide a complete response in up to 70% of patients with HER2 positive breast cancer. We did not have that option 20 years ago. And it's taken us 20 years to work out all these anti-HER2 agents. What are the best ones? And we now know that with particular combinations, we can achieve up to a 70% complete response rate. And where we're deficient at the moment is we cannot predict for an individual patient whether they're going to be in that 70%. That would be an enormous step forward, because if we could predict safely that they were going to avoid, that the drugs were going to work for a complete pathological response, and this is in 70% of women, I would no longer have to operate on those women. And that's a step that's going to come in the next 5 years. We'll be able to predict with greater accuracy who will respond completely to HER2 positive breast cancer. And that's an area of research that I think is really important. And if we can find that out, we would avoid chemotherapy. Sorry, we would go with adjuvant therapy, but we would avoid surgery. You would no longer need to do surgery for HER2 positive breast cancer. I think that would be a wonderful achievement and something that I hope will come in the next 5 years. I just want to show you on the next slide, in hormonal therapy, we have a whole range of treatments. We started with tamoxifen in the 1960s. Arimidex is a anti-estrogen that works peripherally, avoiding the conversion of pre-estrogen to estrogen. Femara is another anti-estrogen known as letrozole, and aromasin is a drug, another variety called exemestane. So these have been significant advances for us in treatment. Here's the list of the anti-HER2 medications, Herceptin on the left and lapatinib on the right. And we now know that pertuzumab is a very powerful drug that can get you a complete response rate in 70% of HER2 positive breast cancers. So I hope you've realized by that section of the talk that Oncotype is a good way of avoiding chemotherapy, and our drugs in HER2 positive breast cancer are very powerful, and someday we'll be able to identify and predict who are the 70% who will get a complete response to anti-HER2 treatment. And the benefit there is no surgery for that group of patients. And that could be 20% of breast cancers. So that's a very exciting change. We've had changes where we've avoided an axillary dissection, and that's very rare in my practice nowadays. And we may be in a situation of avoiding surgery for HER2 positive breast cancer in the next 5 years. I now want to move on to talk about the third really important advance, and it's in the area of breast reconstruction. This has changed dramatically, and I think mainly because of the advent of very sophisticated microsurgical techniques that allowed DIEP reconstructions to be done. DIEP stands for deep inferior epigastric pedicle. It's where you take the patient's abdominal wall tissue and bring it up and do an anastomosis to the internal thoracic artery, very small vessel, and you successfully shape a new breast doing that reconstruction. So as you know, there's immediate and delayed types of breast reconstruction. The rates in Ireland are still quite low at about 30% immediate reconstruction. And there are factors that influence people having immediate reconstruction. It certainly adds to the surgical time. If you have a very advanced stage 4 breast cancer, it would not be recommended. Even stage 3, you might be concerned about it. If the patient has comorbidities, and the patient may just not want to undergo the extra surgery that's involved in a reconstruction. And then the influence of what happens when you irradiate breast reconstructions is very important, because if you irradiate an implant, you have a 30% chance of having a capsular contraction and a poor cosmetic outcome. So the advantages are better cosmetic results, fewer surgeries. The disadvantages of immediate reconstruction, it's a longer recovery and there's more scarring than having a mastectomy alone. A delayed reconstruction, they may be able to have their radiotherapy and not influence treatment decisions. They have more time to consider options. The disadvantages are, a delayed reconstruction, you're without a reconstruction for a number of months or maybe years, and that can be challenging psychologically. The options on breast reconstruction, well, you can use implants, and we do know that in the last year, there's this very rare anomaly that comes from breast cancers. It's a rare type of lymphoma. It's still less than 1%, but they say now that it can occur in 1 in 300 implant reconstructions. Previously, that figure was 1 in 60,000. So people are a little bit more cautious about the use of implants. In my own practice, I have superb plastic surgical colleagues that would predominantly do DIEP flaps, which is taking the abdominal wall and reconstructing the breast with that. And they have on occasion done a small number of taking the inner thigh to reconstruct the breast. So just to show you these, this is the implant-based reconstruction. This is taking the muscle from the back. Tends not to be used as much now because the DIEP reconstruction is so good. This is a TRAM flap, which is outdated. We don't do it anymore. It's where you used to take the rectus muscle, but now we do this procedure, which is where you take the abdominal wall and you reconstruct the breast by taking a free flap of the abdominal wall, bring it up to the internal thoracic artery and reconstruct the breast with that. And they definitely give you the best outcomes. And then I want to just show you a TUG reconstruction where you take the inner thigh you generally can get a smaller breast reconstruction, but in those who don't have enough fat on their tummy, a TUG reconstruction is an option. It's used in about 5% of the time for us in our reconstructive portfolio. So that finishes my aspect of breast reconstruction. So just to summarize, we've talked about sentinel node and how that has changed practice over 20 years, avoided surgery on the axilla. We've talked about Oncotype testing, which has made us more selective in who we give chemotherapy to. We've talked about breast reconstruction, how the DIEP reconstruction is very much a gold standard and the best reconstruction. Implants are still definitely done, but the scare last year of the lymphoma that's associated with implants at a rate of 1 in 300 has caused slight concern about the safety of it, but only slight. And finally, I wanted to finish in my last section of this talk is in the area of basic science, because I do think that research is our way forward. And I want to share with you some of the research that our own group have done in the last decade here in RCSI in Dublin. And I just want to share with you what I think is one of the biggest clinical challenges. So there's 1.7 million new cases of breast cancer annually. The majority are estrogen receptor positive, 70%. Estrogen receptor positive patients receive targeted therapies such as tamoxifen or aromatase inhibitors. But here in the red line, this is the issue. 40% of patients relapse and develop metastatic disease. And we've no way of predicting who is likely to relapse and who is likely to recur. And this is a subject that we looked into intensely in our own group here. And if you can bear with me, I'm going to show you a few scientific slides and try to make this as simplistic as possible. So we try to address this challenge of metastatic disease and the relapse rate. So in my next slide, I want to share with you what we might call our favorite protein. It's SRC1. So SRC1 is a protein that can be identified within a breast cancer cell. It's important in that for us, it identifies that you are likely to recur. So we identified this in a series of 500 patients, that this particular co-regulatory protein made you more at risk of recurring while you're on an anti-estrogen for your breast cancer. And we sought to understand the mechanisms of how this would happen. Now, this is just a slide to show you that if you had SRC1, this molecule, in your breast cancer, you had a worse prognosis. You died earlier. So when we looked at the biology of our cell and we looked at the proteins that interacted with SRC1, we identified that there was, if you had SRC1 in your breast cancer cell, you were going to secrete into the serum a product called S100 beta. And we tried and explored whether this could be a potential biomarker to predict who would be likely to recur from breast cancer. We have published on this area saying that S100 beta can be a potential biomarker to identify those patients that overexpress SRC1. Our dilemma is to get an effective treatment for this particular subgroup by identifying it early. And at the moment, we've looked at various treatments such as dasatinib. However, it's a drug that's used in hematology patients, but it's poorly tolerated orally. So we don't have a complete story on it, But I think it is interesting and one that we should continue to work on to try and find out how you would identify patients who are at risk of recurring. The final area that I want to share with you that we're working on is in the area of breast cancer that spreads to the brain. And we have a unique cohort here, as we have a National Neurosurgical Centre, of patients. As you can understand, brain metastases are not that common in breast cancer, but when it does happen, the outcome is very poor. And we focused on this particular subgroup to try and understand the biology of why patients might develop brain metastases. The outcome is very bad, but we do think there's a different environment within the brain. And we've also looked at what happens with HER2 treatments in brain metastases. And we've looked at what happens if you block HER2, give an anti-HER2 treatment. And we're trying to look at differences between the primary tumor and in the brain metastasis. And we're very hopeful that we will understand when you have your primary breast cancer that might be HER2 positive, what happens when it actually ends up in the brain? And is our anti-HER2 treatment forcing a different clone of breast cancer? So we have a large biobank of patients who've had their primary breast cancer, their lymph nodes, and their disease in the brain. And we're trying to understand the processes as to why it particularly homes in on the brain as opposed to other places. So it's an ongoing field of work. I highlight this because there is so much more knowledge to identify in the field of breast cancer. Over the last 20 years, we've made significant progress on the surgical side. We do less surgery to the axilla because of sentinel node mapping. We give less chemotherapy because of advances in diagnostic tests such as Oncotype DX. Our ability to do much better breast reconstructions with DIEP reconstructions has improved immensely. And I share with you at the end this story about the biology of breast cancer. And there's so much more for us to learn as to how can we actually make a difference to this disease. So it's an exciting area. I think there will be ongoing changes in the years ahead. I hope there will be less surgery. But I think what we're learning about breast cancer is more and more, and we're going to learn about people who are genetically predisposed to it with BRCA1 and BRCA2 mutations. And I think there will be a lot of surgery for patients in a risk reduction format, trying to reduce their risk of breast cancer, those who are genetically predisposed to it. I'm going to stop at this and thank you for listening. And I hope I've given enough time for questions. We have 20 minutes or so to take questions, and maybe I can go back to my moderator, Kasturi, who might be able to field any questions that come in.
Yes, thank you so much, Prof, for that informative session on breast cancer. So we'll move on with the Q&A session now. Would also like to drop a gentle reminder to audience to keep sending in your questions, and we'll try our best to address them now. So the first question that we have here is from Mr. Sharo. What is the difference between the Oncotype test and Onconomic test done by the RCSI lab?
So Oncotype DX is a particular test that looks at 21 genes, and I think it's predominantly based on the response to HER2 and ER positive. Can you just repeat what the second one that was similar to Oncotype? What was the word?
Oncotype test and Onconomic test done by RCSI lab.
So Onconomic test I'm not familiar with. It may be a derivative. I'm not sure. It may be a competing trade name looking at the same area, but Oncotype DX is probably the most widely used recurrence score predictor.
Okay, Prof. Thank you for answering that. And the next question, good evening. I did not catch the part of the talk where you mentioned how staging groups, such as isolated tumor cells and micrometastasis, do not affect the outcome of patients. How exactly does it not affect the outcome of patients? Thank you.
So it's a great question. We spent 2 decades looking at this, and I remember when 20 years ago in practice, when we introduced Sentinel node, I would have patients who would have isolated tumor cells in their Sentinel node. And at that time, we were so scared about the biology, we went on to do an axillary dissection. And I've published on this. We have a series of maybe 20 or 30 patients where we looked at the outcome on patients who had isolated tumor cells and went on to have an axillary clearance. And we found that none of the patients ever had further disease in the lymph nodes. So it was studies like that that made us realize it was safe to avoid isolated tumor cells. The next issue was the issue of micrometastasis. And there was a series published in the Journal of Clinical Oncology that looked at a cohort of patients who were micrometastatic positive, and half of them got chemotherapy and half didn't. And the chemotherapy did not make any difference to survival and outcome in those who had micromets. So it's good, persuasive evidence in the literature to say that it doesn't affect your long-term outcome having a micrometastasis or having an isolated tumor cell.
All right. And the next question, Prof. Okay, give me a second. What are your comments on neoadjuvant chemotherapy and immunotherapy on breast cancer as a systemic disease?
It's a great question. Let's take neoadjuvant first. Neoadjuvant chemotherapy, I would regard now as standard of care in HER2 positive breast cancer. The reason being, we have this cohort of 70% that get a complete response. And I think that's a group that, as I said in the talk, we want to identify who are that 70% and can I avoid surgery? So I think neoadjuvant treatment pathways, it should be standard of care for HER2 positive. Maybe I should say HER2 positive, it's more than 1 centimeter in size, because it may be over treatment to give HER2 treatment for a really small tumor. You could argue just take it out and they might be fine. So I think anyone with tumor over 1 centimeter probably should consider treatment, neoadjuvant treatment. The issue about immunotherapy, its role in the area of breast cancer is probably not as advanced as we would like. I think we definitely do have drugs that affect the immune system. They're particularly relevant in melanoma and lung cancer at the moment under the label of immunotherapy, but I'm sure they will be available in the breast cancer area soon.
All right, there's another question from Ms. Regine. Hi, Prof. May I know more about the cryoablation treatment, freezing of breast cancer tumor, and what type of patient is suitable for this?
Yes, so this has been explored particularly by a group in Cornell in New York, and there's been trials by the American College of Surgeons Oncology Group looking at this. The slight problem, I think it can be safe and considered for people with very small tumors. The only reservation I have is that I think we learn a lot from understanding the biology of an individual patient's tumor. And you could get a core biopsy and get a lot of biological information. But when you freeze the tumor, you're essentially destroying that tissue and making it very difficult to treat the patient based on their biology. I think it's one way of destroying the tumor. Whether it's substantially better than excising the tumor, I'm not sure the evidence has been there for that. And I think its role at the moment for cryoablation is in really small tumors, and maybe there might be a role there for that. Having said that, I'm still uncomfortable with destroying tissue that we like to understand the biology more with. So I don't practice it. I think there is a small indication for it.
All right. Next question from Ms. Jayashwini. Hi, Prof. Is there a similar test to predict the response for radiotherapy, like the Oncotyping DX for chemotherapy?
So the simple answer is no. They've actually looked at the benefit of Oncotype test in trying to decide whether you need radiation treatment, and there is a role, I think, for exploring that further, but I haven't seen the published data on it. And no, there isn't really a good test equivalent to Oncotype that says radiotherapy helps or not.
Okay, another question. Hi, Prof. Thank you for your informative talk. I would like to ask, with the advancement of chemotherapy, will surgery and drug therapy, still play an important role in future? Thank you.
Yes, I think I mentioned that at the end, and maybe I should make it clear. I do think that for HER2 positive breast cancer, there will be a day that we will not be operating, for sure. I think that day will come, and hopefully soon. I think where surgery will remain important is in the prophylactic risk reduction surgery in those who are mutation carriers. So I think that's an area that we will change our practice.
Okay, and moving on with the next question. Is there a link between hormone replacement therapy and breast cancer?
For sure, we know from the Million Women study that if you take HRT for 5 years, you increase your risk of getting breast cancer. That's a definite. It's a very difficult area because there are lots of people out there who are postmenopausal, have a slightly increased risk of getting breast cancer, and they may have terrible postmenopausal symptoms, and they may want to take HRT. So my advice to such patients is, as long as they understand the risks, they can choose to take the HRT if it substantially improves their quality of life. The risk of breast cancer, we know if you stop HRT after 5 years, you lose that risk of breast cancer, which I think is equally important. So one could talk for an hour on HRT and breast cancer, but I think that's a very brief summary.
All right, and moving on with the next question. How do I manage the side effects of breast cancer treatment?
So it depends on your side effects, if you, and what you're taking. So if it's tamoxifen, some people find that, even though it's the most widely prescribed anti-cancer treatment, some people find that difficult. I would move my patient to an aromatase inhibitor. And as I showed you on the slide there, you have 3 aromatase inhibitors. So between Arimidex, letrozole, and exemestane, I think you've got a good range that should find something suitable for the patient who's ER positive. However, there are a few patients who just can't tolerate it, and they just think the side effects are worse than the anything else, and they don't end up taking anti-hormonal therapy.
All right, Prof. Another question from Ms. Regine again. Are there any patient who is ER/PR positive who relied on medication such as Femara instead of undergoing surgery?
Oh, for sure. So in the elderly, we have studies looking at hormonal treatment as an option, as the only treatment for breast cancer. And we know that in the elderly, it certainly buys a lot of time, but we feel that in the younger patient, the best option is to actually give surgery first. And there's many trials looking at that. So in a younger patient, surgery is definitely the best option. But it's an acceptable alternative in the elderly, and by that I mean over 80, to consider hormonal treatment only for ER positive patients.
Understood. And apart from the Oncotype DX, what are your comments on other molecular tests such as PAM50?
So the one I practiced with was Oncotype DX. I did mention there's ones like Mimpara. Sorry, I beg your pardon. There are various other, Mammoprint is the other one that is used in Europe. And I think there will be a commercial range of them now, all doing the same thing, trying to predict the outcome from breast cancer. And I'm not familiar, I work most with Oncotype DX.
All right, Prof. And another question, is there a possibility that the breast cancer recur after a mastectomy?
For sure, we do know that after a mastectomy, there is still a recurrence rate. The longer you follow your patients up, there will be a recurrence rate. So you can get a recurrence on the chest wall. It's low, it's single figures, maybe about 2%, but it does happen.
Okay, and the question on your on the part where you explained on breast reconstruction, will reconstruction interfere with chemotherapy?
No, reconstruction done safely and done well shouldn't interfere with chemotherapy. I guess the issue is if you do a reconstruction and you get wound problems and flat failure and delay the onset of treatment of chemotherapy, then that's an issue.
All right, and another question from Ms. Lim earlier, and will the drug therapies explained earlier affect the effect of breast reconstruction?
I think breast reconstruction is pretty safe to do. And as I said, there are cohorts who you might prefer to do it in the immediate setting and cohorts who you might prefer to do it in a delayed setting. But the drugs don't really cause us any concern.
All right. And another one, how exactly aging affect the reconstructed breast?
So the reconstructed breast, if it's with a DIEP, does exactly the same as your tummy would have done. So if you get a DIEP reconstruction, you've reconstructed your breast, then go and eat cream cakes and put on weight, that breast will get bigger just like your tummy would have got bigger. If you start to lose weight, it'll also lose weight. And likewise in aging, the consistency of your tummy at the age of 85 is different to the consistency of your tummy at 40. So the consistency will change with age. So yes, we don't have an anti-aging process yet. You'd be very popular if you did. It'd be better than beating breast cancer, for sure.
Okay, and let me see. Okay, if using a tissue flap, will you also need to place an implant to give the reconstructed breast a better shape?
So it depends on what you plan preoperatively with the patient. So you would work all that out beforehand. So usually if you're doing the DIEP, you don't need any implant. Sometimes with an LD, they do an implant, but not with. It's known about it when you plan an implant reconstruction that you're going to use the implant.
Okay, so maybe we can take one last question.
Okay.
Right. Okay, this is about the sentinel lymph node. What are the benefits and risks of the sentinel lymph node biopsy?
So the benefits are that the sentinel node will identify in one node under your arm whether cancer has moved there. And it's a very minimalist procedure. It's a day case. So I think it's a wonderful advance in breast cancer treatment. And you get a good chance of understanding a lot of biology should there be a positive node. And that'll help you make a decision as to whether you need to remove other ones. So I would be a big fan of sentinel node mapping. I think it's a good thing in breast cancer, and it's changed how we practice.
All right, thank you. Thank you so much, Professor Hill, for your time today. And with that question, we have reached the end of today's event. Prof, do you have any final note to our audience today?
Yeah, I just want to thank everybody and my friends, and I'm just delighted to be able to talk to you this afternoon. It's always a pleasure to engage with you. I must say you've been a very responsive audience. Those questions are certainly grilling. And Kasturi, thank you for being so kind in asking them in a friendly way. So can I thank you all for the opportunity of presenting here today. It's a great honor. I look forward to doing it again at a future date, and I hope you all enjoyed the talk. So thank you very much.
All right, probably welcome. And okay, to the audience, if you have any other questions, you can please feel free to email us at inquiry@rcsiucd.edu.my. And once you leave the session, you will receive a short survey on today's keynote session, and we would appreciate if you would complete that and provide your feedback. You will also receive a follow-up email within 24 hours with a link to view a recording of today's event. And finally, on behalf of RCSI and UCD Malaysia campus and our speaker, Professor Arnold Hill, we would like to thank you for joining us today. Till we see you next month in another session of the Keynote Speaker Series. Take care and stay safe, everyone. Thanks, Prof. Hill. Goodbye.
Thank you very much. Bye now.